So let me first thank the event organizer for inviting me here today and for allowing me to speak alongside distinguished guests. My name is Dr. Kamal Amzan. I'm the CEO of Gleneagles Hospital in Medini, Johor. Johor is the southern state of Malaysia. It's just 20 minutes away from Singapore, 2.5 hours away from Bangkok, 1 hour ride away of ferry ride to Batam, 1.5 hours flight to Jakarta. So the hospital is located at the southern tip of Malaysia. We are a 300 plus bedded hospital, tertiary, and some of our key features would be in the areas of cancer treatment and minimally invasive surgery. Cancer treatment, we house our nuclear medicine department, and the first digital PET scan in Malaysia is actually in Gleneagles Medini, Johor. In the field of minimally invasive surgeries, we are home to robots for arthroplasties and of course for your prostatectomy. So ladies and gentlemen, I am here to share with you the journey that Gleneagles Medini took throughout COVID-19, and perhaps we can share the gems within. Gleneagles Medini is part of the clicker. You have a clicker? This is a clicker, is it? All right, sorry. It looks a bit different, all right, okay. All right, okay. It's not working, yeah? It's clicking. So Gleneagles is part of IHH Group, right? And we have, our footprint is across 10 countries. We've got 6 leading brands. I'm sure you've heard of some of them, including Prince Court Medical Center, Gleneagles Hospital, Pantai Hospitals. In Turkey, you've got your group of hospitals called Acibadem. We've got more than 15,000 licensed beds and more than 65,000 employees. Now, before I can share with you our journey, I will need to share with you what actually happened to the country, and I'll take you step by step through it. Okay. So, unbeknown to many, the first 2 cases of COVID-19 in Malaysia were accepted in Gleneagles Medini. Now, to accepted is a strong word. We didn't have a choice, right? So perhaps to receive. So we received the first 2 COVID-19 patients in Malaysia in Gleneagles Medini. And these 2 patients were from Singapore. So we were alerted by the Singapore health authorities. We informed the Malaysian health authorities. We had to place the patient in quarantine and facilitate their transfer to the government hospital. Now in Malaysia, whenever we talk about emerging disease or new diseases or infectious disease in particular, the private hospitals don't manage them. We send them to the government hospitals for 3 main reasons. The first is for the country to study the nature of disease, the progression of disease, the complications and its sequelae, and come up with a repository of information that both the private and government can tap into. The second is the resources that the government hospital has. The network of government hospitals that they have across the country would allow easy transfer of patient from one hospital to the other. And in Malaysia, the Institute for Infectious Disease is funded by the government, is at the government hospital, so it makes more sense for them to house these patients. The third reason is synergy. The entire government hospital, the network of government hospitals, they are very cohesive. They work as one. So they can transfer resources, transfer manpower, transfer knowledge quite easily. On the other hand, the private hospitals like Gleneagles, though we are fully equipped, we are individuals and we are quite independent of one another, right? So a bit of history. Now, our first outbreak was in March 2020, and it was due to a religious gathering. For a country that has not seen COVID-19, having a 7-day average of about 90 is quite scary, right? So when we saw COVID-19 in March, due to the outbreak, the government imposed strict lockdowns. No traveling, shops closed, can't travel interstate. That was the first. And because of the strict lockdown, the outbreak abated, all right? And life went on as usual. We were able to cross the state. We were able to meet family members in Sabah, in Sarawak, in Borneo. We were able to cross north and south, right? But then September 2020 happened. And this is now academic, but in September 2020, there was a by-election in Sabah. Sabah is part of Malaysia in the Borneo Island, right, across the South China Sea. So when there was an election, you've got politicians, public, you've got campaign workers, you've got party supporters crossing over to the other side. So they went house to house campaigning. They talk to canvass votes. They go into the rural areas to meet with the rural folks to gather support, right? And during polling day, everyone came out into the polling area to vote. And after the election is done, everyone came back to the peninsula. And when they came back to the peninsula, they're across the country. They're not in Kuala Lumpur alone. Some are from Penang, some are from Johor, some are from Langkawi, some are from Pahang. And given the incubation period of 3 to 5 days, doctor? 3 to 5 days, right? So many of them were asymptomatic. And many of them were staying with their parents, with their family members, the children, the elderly, those with comorbids and whatnot. Now, then of course, there's this issue of stigma. By September 2020, people are worried that they are labeled to have COVID-19. So nobody wanted to tell you that they've got COVID. And since they just came back from hard work in Sabah, they attributed the non-specific symptoms of arthralgia, myalgia, body ache, and fever to fatigue, right? So that caused the second wave all the way until year end and early 2021. The government imposed another round of lockdown, but that did not help because that disease, that outbreak has spread across the country, north, south, east, west, everywhere near you. And at that point of time, we didn't have the vaccines. So the old, the vulnerable, the ICU rates were high, admission rates were high. And it didn't come down until at the end of 2020 and early 2021, early 2021, when we started vaccinating our population. We started with the frontliners, the doctors, the nurses, the police officers, the soldiers, the emergency workers, those who are above 60, those with comorbids, before we vaccinated everyone else. And once we have reached 80% of vaccination across our population, only then did we see the number came down. And that was in September 2021. All right. By then, though the number kept increasing due to Omicron, but because we have vaccinated enough population, the number of ICU admissions remained low. The number of admissions into the public hospitals and the private hospitals continued to remain low. So the vaccination, we completed, I think at this point of time, completed booster and whatnot, but we worked with the government to vaccinate Malaysians as a whole. Now, remember I told you once earlier that whenever we look at emerging disease or new diseases, it's the public hospitals that bear the brunt of the patient. And that's because they've got better resources, they're able to mobilize resources, they're more synergized in terms of their response, right? But by September, October, November 2021, they realized that that cannot be the case anymore. They needed help from the private sector, and the private sector were roped in to help the government in managing COVID-19. And because of that, we had to set up our own command center at corporate level. Now we have 16 hospitals in Malaysia, Pantai Brands, Prince Court Hospital, and Gleneagles Hospital. So we had to set up a command center to mobilize our resources because our resources are finite. As a private hospital, our main core of patients and treatment, or business if you will, is not in the infectious disease. We deal a lot of trauma, cancer work, surgery, minimally invasive, technology, advanced and assisted surgeries, right? Not so much on your non-communicable diseases, infectious diseases. All these are usually run by the government. But when the government needed our help, we had to step in, and we established our own C4, Central COVID Command Center, all right, that we meet every single day, chaired by the country CEO, to mobilize resources and talk among each other. So among the issues that we discussed, number one would be the updates from the Ministry of Health with regards to protocol. The second would be the allocation of resources, because some hospitals would have more, some hospitals would be less, and how do we then mobilize these resources over? When I say resources, I'm not just talking about beds and ventilators, I'm talking about human capital. Because some hospitals that are smaller, the outbreak may be bigger, they will have a higher surge. So the bigger hospitals will have to send our human resources all the way up to support these hospitals, right? And of course, we have to have our own repository of information so that we learn from our mistakes and then move forward. Now, that is at the central side. At the hospital level, we set up our own to mirror the committee that was set up at the corporate side. So at the hospital, we call it HIDOC, Hospital Infectious Disease Outbreak Committee. And this is, again, to facilitate communication with the staff. At that point of time, there was so many communication, verified, not verified. Doctors were saying one thing, the management was saying another, the government was saying something else. So we had to sit down together and formalize or streamline our communication, not just to the doctors, but to the media and to the public. Right? So the composition of this committee, myself, the infectious disease physician, you've got physicians, you've got nursing, the human capital side, you've got the head of medical affairs and quality, etc. Now, so apart from communication, we also developed policies. There were so many policies from CDC, and because we're just next to Singapore, there are so many policies coming up from the Ministry of Health Singapore. We've got policies coming in from Ministry of Health Malaysia, and they may not always be the same. So some doctors will want to follow Singapore, some doctors want to follow CDC, some doctors want to follow Malaysia. So we have to sit down, agree on a consensus, adopt a policy, and move forward. All right? So that is one. Then the workflows and protocols. As a private hospital, again, we don't deal with infectious diseases. Our emergency department is built to deal with trauma, to deal with all these emergencies, not your COVID-19. Right? So we don't have enough isolation rooms and all that. But because of that infrastructure limitation, we have to redesign the workflow, the protocols, and educate the staff. And that was one of the responsibility of HIDOC. And once you have that, of course, ladies and gentlemen, you know, policies without supervision and follow-through is useless. So HIDOC also formed a committee to walk around, the leadership walk, we call it, the CEO, the MD, the infectious disease chairman. We will walk around to make sure that the policies we crafted, drafted, and implemented is actually executed on the ground. Yeah. Right, so we made some changes to the hospital. We only had one isolation room in the emergency department, mind you, 300 plus bedded hospital, state-of-the-art technology, robots to assist in our surgery, nuclear medicine department with PET scan, digital PET scan that can do gallium study. We only had one isolation room in the emergency department because there was no demand. There was just no demand, right? But during pandemic, we had to quickly create new isolation rooms, put up barriers in the ICU, change our ventilation, all right, create more cubicles, and if you look at the, is there a pointer? Sorry, getting very old, I can't see anymore. Where is the pointer? Oh, okay, all right, thank you. Okay. Oh, sorry. So this is a portable isolation room. So we got some of those because we can't renovate the structure that is built 5 years ago without thinking that a pandemic will happen in future. We can't. It will just require too much time, and by the time we finish the renovation, the pandemic will be over, or we will be over. So we had to come up with mobile solutions to cater for that demand. Right? Now, helping the government is one thing, creating infrastructure is one, but we know that if we don't help the government to vaccinate Malaysians, the pandemic will never go over. So we helped the government in our vaccination program, and IHH, as a group, we vaccinated 740,000 Malaysians. Gleneagles Medini on our own, we vaccinated 250,000. At one point, we were vaccinating 5,000 Malaysians per day. That is from our own pocket. We opened up halls, we recruited doctors, nurses, allied health, and all that, and we helped the government vaccinate patients, Malaysians. The cost is on us, the consumables is on us, all the infrastructure, the fees that we paid to the doctors, the nurses to administer all this is borne by the public's private side, by the hospital. Right? Now, some of the issues that we had learning from experience, right? The first is when the lockdown happened, a lot of our patients who would require treatment and follow-up, those with NCDs and whatnot, didn't come. They couldn't come. Even with the letter from the police, they couldn't make it. The second is non-optimization of resources. I have isolation rooms everywhere in the hospital except ED. Every ward will have one. But when I open a COVID ward, none of the rooms are isolated. Right? I only have one isolation room for every ward, but when I open a ward for COVID-19, I only have one, and it doesn't help me. So how do I do that? Another problem I had was resources. The customer care, the operators, they didn't have things to do. Well, people were not calling. The customer care didn't have any service recovery to make, but they were all over the hospital and I couldn't track them. That's the second issue. The third one is the fixed infrastructure model. Like I mentioned earlier, all the isolation rooms are built, are fixed. I can't move them. I need to move the patient to the room. If I could, I want to move the room to the patient, wherever the patient may be. That will solve a lot of my problem as a CEO. And the fourth is the emergency department that is too trauma-focused. We are too trauma-focused. We have a blood bank, we've got emergency physician, we've got trauma surgeons and whatnot, but we only have one infectious disease doctor. So what did we do? So of course, we went online. We went digital. We've got e-health. Patients can now talk to their doctors online. We give patients BP sets and sugar glucometer to monitor their sugar at home and talk to the doctors. All right, so they don't have to travel anymore, because as a tertiary center, we receive referrals from across the country, also from Indonesia, also from Thailand and Singapore. Right. The second one, we're exploring mobile structure. So instead of building, okay, thank you, time's up. Okay, so instead of building a fixed isolation room, we are now looking at a mobile isolation room. So instead of moving patients to the isolation room, if a patient is in a ward that is not isolated, we'll be able to mobilize this room to the patient. It's done. The third one is Grab Porter. To manage the resource, non-optimization of resources, the manpower that I can't account for, they now have RFID. All right, so wherever they go in a hospital, it's like Grab. So if someone needs a porter, they press a button, the nearest porter will attend to them, and off they go. All right, but this requires a lot of effort in terms of mapping of job functions, getting buy-ins from different heads of departments, etc. But these are some of the key learning points. Right? And our emergency department now, instead of having one isolation room, the entire emergency department has a negative flow. So not just rooms, but the whole emergency department is now negative flow. So if there is a COVID patient in the department, all right, it will not go out. All right? The air is not circulated back into the public. Right? And this negative flow emergency department is the first in the region. When I say region, I don't mean Singapore, Thailand, and all that. In the region of southern Malaysia, all right? Just to be clear. All right. That concludes my presentation. All right. Thank you very much, everyone.
Well, first and foremost, I'd like to thank the organizers and Cindy and Eva for getting me here. It's always a pleasure to share with you our experience and insights on COVID-19 in the Philippines. I'd like to show you a video first.
We have discovered our power to change things, the power to make significant contributions, the power to make a difference.
So good morning, ladies and gentlemen. My name is Eugene Ramos. I'm a doctor. I'm a cardiologist. I'm also the president and CEO of the Medical City Enterprise, the largest healthcare network in the Philippines under a single brand. The COVID-19 crisis has taught us many, guide us in the decisions that we make as we put order in and add value to our lives individually and as members of society. The disruption that the pandemic has caused has removed deterrents, distractions, and practices that we had to live with in the decades that preceded it. The old normal that defined us as a people and which explains why we are where we are. The pandemic was like a storm that drenched us in fear and uncertainty, inundated us with many unknowns, what-ifs, and false information, and washed away firmly held beliefs and biases that have proved to be irrelevant and of little value. Momentarily, our vision blurred and our joints froze, but quickly, as the relentless crisis evolved in our midst, the neurochemicals in our mind and body kick-started self-perpetuating adaptive responses to the stresses that we could neither fully fathom nor control. Our mental composure took a hit, but our resilience kept us engaged with the tough challenges of keeping our focus. We all have stories to tell, but none more compelling than stories of triumph, of life over death, resilience over fear, human kindness over greed and indifference, and enlightened leadership over mediocrity and bigotry. COVID-19 has shown us many silver linings, providing leadership opportunities to those who possess an accurate appreciation of reality. Something as horribly overwhelming as the pandemic seemed to have imprinted an indelible mark on our souls and has changed it. We became aware of the interconnectedness and interdependence of everything and everyone, appreciated the importance of community and collaboration, and acknowledged the priority of addressing what would work best for many over the overindulgent preferences of the few. It is not at all unrealistic to hope that long after the havoc has fully dissipated, the experience of shared responsibility during the crisis and what other crisis that may follow would make way for a new social order. In fact, I think it has already begun. More than 2 years thereafter, the morning after the storm, we are still here, standing, now equipped with the knowledge gained from the debacle and a glimpse of what must be redone to shape the future. There is no reason to go back to the way things were. To adapt means to reinvent and innovate, give up old habits, and develop new ways of thinking and doing. This is where we find ourselves now. A lot of things happened or did not happen fast enough. In the healthcare sector, through the surges and the variants, the regulatory hits and misses, and the shifting vulnerabilities and predictabilities of patient journeys in and outside hospitals and across the entire health ecosystem. Still, updated medical facts and algorithmic disease management had put fear and uncertainty at bay. Science has provided clarity and confidence in the diagnosis, treatment, and prevention of COVID-19. Molecular labs have risen in many places, perhaps late for the current pandemic, but ready for the next one. Scientific discipline, amid the deluge of fake news, has reoccupied its proper place in the hierarchy of medical information. Digital technology has quickly taken root and transformed everything in its wake, clearly paving the way for the new normal that we have begun to savor. The safety and convenience regulations under quarantine conditions obviously accelerated its early adoption. But just as quickly, it acquired a life of its own, permutating into many possibilities in as many vulnerable industries where the need for speed of delivery, accuracy of data, and the experience of comfort and convenience have become a baseline minimum requirement. In the aftermath, we see around us social and economic structures that need to be repurposed, rebuilt, redefined, replaced, or forgotten. Understanding this shift, automated processes and digital transformation were introduced in our hospital with improved features and functionalities of our IT systems. Our team implemented a more robust system for key hospital processes and services. The digitalization of medicine brings science and technology together in a sphere that is most positive and promising to humankind. Disrupting time and distance, the opportunities provided by digital technology to take healthcare to much higher levels are there for the taking, limited only by our imagination and the readiness to embrace them. The availability and application of new knowledge have significantly improved the patient journey from home to hospital and back. In fact, with online consultation and telemedicine and other rapid changes in digital technology, hospital and home can eventually become one and the same place, because many things can be accomplished anytime and anywhere without having to suffer through distance, traffic, and pollution. As this emerging virtual care increasingly acquires sophisticated technology, and access to reliable information becomes a simple finger activity, the evolving home, hospital, and patient-physician interfaces will redefine hospital care and clinic practice, something that both the public and the medical profession must urgently prepare for. We launched the first institution-based telehealth platform in the Philippines to provide digital healthcare access to our partners and patients and potentially create new ones in the virtual environment. Through our digital platforms, we are now in a position to trailblaze in the virtual world with public awareness of our brand of care, achieving the value of trust. As our technology usage continues to grow, we will leverage our advantage to become digital leaders in healthcare delivery. As the physician-patient interface changes, the physicians themselves must lead rather than be led by the changes that are transforming healthcare. The traditional lone wolf private practice model may no longer be tenable in the long term, as the sea change in the regulatory responses to the rising healthcare cost nixes the fee-for-service model for a less costly but more efficient, data-enhanced, and technology-driven model that provides easier access to more people and with better outcomes. The Medical City Enterprise launched its 2022-2025 plan entitled TMC Care Anytime, Anywhere, which builds on the rapid changes in the market made manifest during the pandemic and addresses the 4 patient-centric healthcare delivery channels anywhere and anytime the patients may be. Acute care in the hospitals, ambulatory care in the clinics, remote care, which has the home care component and the virtual care teleconsultation component, and community care, which includes corporate health and wellness. But even prior to the launching a roadmap to the future, we were already in the business of digitizing health. In October 2020, the Medical City, in partnership with a local provider, launched its COVID-19 home care program to provide hospital care for patients with suspected or confirmed COVID-19. Testing positive for COVID-19 evoked anxiety, but for mild to moderate cases, there was no need to travel to the hospital and queue for admission. With this program, close monitoring of patients at home until recovery diminishes stress and congestion in the hospital. The home care providers industry is among the fastest growing healthcare industries without let-up. With the prevalence of chronic diseases, a growing aging population, and growing physician acceptance of remote care, demand for home care continues to rise. It is not just the pandemic that is causing these shifts in healthcare. They have been coming for a long time due to a bloated healthcare system that has become so expensive to maintain. On the government front, which had been marred by regulatory bottlenecks and mishaps, the full vaccination of more than 70 million Filipinos has been reached. Booster doses have been ramped up despite hesitancy in implementing boosting protocols for specific populations. And the vaccination of children has also started. Looking back, it would seem like the Philippines was not as efficient as its ASEAN counterparts in tracing, testing, and treating the virus spread, despite the stringent government regulations and restrictions. But Filipinos cannot be faulted for non-adherence to government protocols that didn't make sense. When citizens have the correct information from the government, they do follow the rules. While it is apparent that the COVID-19 virus and new viruses will continue to be present, 2 years of the worst part of the pandemic have given us radical lessons on change, adaptation, and transformation as we engage the new world. Armed with knowledge and confidence, we are realizing that the future is not some place we can only walk towards. It is something that we must create. Years from now, the world may be facing an entirely new set of challenges. All we need to do is to remember our collective past, appreciate how we survived, and prepare well. Things that we cannot control, we hand to nature. But consider this: we have more control over ourselves than what we are ready to confront. Just a closing video, and I'd like to say thank you to everyone.
Good morning, everyone. So I'm I would like just first to introduce myself. So I'm Professor Leti Anthu. I'm the Group Chief Medical Officer of Hami Medical Corporation. So this is the the hospital chains with 15 hospitals and 7 clinics around Vietnam. And I also the president of Vietnam Infection Control Society. So it's my great honor to be able to present with you today. And I would like to take this SMI organizer to give me this opportunity. So today I would like to talk about the, learning from COVID-19 and our the past crisis to create a future-ready solution. So I hope that you all agree with me that after passing the long pandemic of COVID-19, this is the time that we should review what we can learn from the pandemic, and we need to explore the ready solution for the future occurs that may occur in the future. So therefore, in my presentation today, I will discuss with you the two following content. Firstly, what are the lessons we learned from the COVID-19 and other past crises? And the second, what it should to do to create a future-ready solution. This is the WHO dashboard for COVID-19 that we have received the update every day. So for nearly 3 years, until the 1st of September, still more than 600 million people been infected, with more than 6 million foreign deaths. And this number is still counted continuously, and we still do not know when we can say that the pandemic is ending. With this in mind, let's look at the past pandemic from the 19th to the 21st century. So most of them are the influenza pandemic. And the pandemic occurred with the cycle of every 10 to 30 years. We had the Russian flu H3, and then Spanish influenza H1N1, and then Asian flu H2N2, and Hong Kong flu H3N2, and most recently H1N1 in the 2009. So we can see that after it takes nearly 2 centuries that all the types of influenza now become to change to the seasonal flu. So now H1N1 or H3N2 all is seasonal flu, and all can be vaccinated for prevention. So the most pandemic in the past that makes us usually remember before the COVID-19 were the Spanish flu pandemic spread worldwide during 1918 and 1919. It's estimated that about 500 million people, or 1/3 of the world population, became infected with the virus. So as we can see from this paper, how difficult that we had to face with when the disease comes and see the capacity of the healthcare service. So more were taken off the train in the dying condition. The sites were brought to us by the hundreds. And every train load the brought more debris, sick boys, something like that. And the patient should stay outside the hospital because there's no hospital to accommodate them. And for example, in this photo, we can see the patient stay in the church and even stay in the field under the tent. So, and now, after after more than 100 years, in the 21st century, we still had to face with the similar situation. In my country, in my country, we also have passed the most difficult time due to the rapid increase of COVID-19 cases that beyond the treatment ability of the current healthcare system. The number of cases increased dramatically in a short time, which exceed the ability of healthcare system in Vietnam. Similar to the pandemic in 1918, we no place in the hospital to accommodate every patient. Not enough ICU bed to receive every patient, and many patients die at home without treatment. So in this situation, we had to change the way to care for the patient. So everything was at home. Patients to test by themselves or healthcare workers come to their house to test, as you can see in this photo. And when they become the positive, they will give the drug at home as well. And even when they need, then require the oxygen, we also supply the oxygen at home. So in order to help the people to care for at home, the MOH even supply the guide to make the quick test at home, the guide to use the rack bed at home, and even the guide to use oxygen at home. So as a consequence of this crisis at this time, the COVID-19 became the third top mortality of Vietnam during this time. So this is the milestone that we have not forgotten to learn how to respond better with the pandemic. Looking to the global response to COVID-19, every way of COVID-19, we have many ways of quantifying it, and every way usually go through 4 phases. Firstly, the people feel shocked and radically recognize the situation, and then the situation becomes severe. The affected region should be locked out, and then after that, we go to the stable ramp-up, and we try to prevent, to stop in the new normal, to prevent the next wave. So from this, we can see that for better control the pandemic, it's very necessary that we need to early recognizing. That means early screening, early diagnosis, and treatment of the disease. We need to take very quick prevention and control of transmission, like isolation, social distance, mask, and hygiene or disinfection. And also very important that we to early vaccination. We usually talk about the 3T, test, trace, and treat. So which T is priority is depending on the phase of the pandemic. For example, at the first time, when some cases, the test and trace is very important. But when there are many cases already straight, so the treatment is very important to make sure the patient can be treated. But I would like to emphasize a bit about the vaccination, because I think that the most important epidemic prevention and control measure is promoting the vaccination. And to promote the vaccination, it requires the capacity in development, production, cold chain transportation, and distribution. Another lesson that we can learn from the COVID-19 is that besides the severe impact of COVID-19 to us, for example, the loss that we had to face, like high mortality, down economy, is there any positive change emerging through COVID-19? The big positive thing I can see is the change in infection control mindset. Before that, I can see that the better infection control compliance, both in community and hospital, is established. For example, in the 220 Bradley Corporation have made the survey and show that the hand washing has increased during COVID, what they call coronavirus hand washing effect, and 78% of Americans are now washing their hands less than 6 times a day. And not only in the community, but also in the hospital. Rosina Santan has published a paper to show the trend of hand washing compliance and the sanitizer consumption increased after the COVID-19 occurred, and at the consequence, the hospital-acquired infection was reduced. Another positive change from after COVID-19, I think, is the development of the telemedicine. So the lack of capacity of the hospital that made the treatment change. As we can see that we had different state model of the healthcare service to manage the COVID-19. So there is a movement from the hospital care to the home care. As we can see, at the stage 1 and stage 2, the patient can be guaranteed at home, or can be received in the home care, but they only need to go to the hospital for ICU when the resources end. So that is what we have learned. So what we should do to create a future-ready solution? I think the first thing that we discuss about the shift to the telemedicine. Telemedicine can help to reduce the pandemic by reducing the number of hospitalizations and enhancing the social detention. As you can see here, we can triage the patient online by auto-questionnaire, and we decide who will need teleconsultant and who we need to admit to the hospital. And even in the hospital, we can also do the tele-expertise with the specialist, tele-radiology also, and even tele-ICU. And Mahomet has proposed that this can be considered as an alternative technology-based preventive measure may empower the healthcare sector in the long term and enhance social distancing. Well, we all know that prevention is always better than treatment. If the disease can be treated at home, it's always better than the disease that requires hospital. When we enhance in the home care and the prevention, we can increase the ability of home care and proactive healthcare service. With the support of digital technology, we can create a care network that shifts from the institution to preventive home care, shift from the population points on the immediate need and treatment, and shift from the solo to community and team-based care with the cost abundant. So digital technology can be applied at the single device and the whole solution for each individual for better home care. So, and we can see that Lotus and his colleague has recognized that up to 600 billion worth of care service from Medicare could shift from the traditional facility to by the home by 2025 without a reduction in quality of asset. Secondly, the maintaining and enhancing the involvement of the compliance about prevention and control of infection control, the community and hospital is always necessary. The basic measure of infection control like hand hygiene, mask, environment is always very important to be reminded. But the most important that you can learn that from the pandemic, the respiratory infectious disease is only the pandemic, so it requires the good ventilation. So open design is preferred than closed design. So that's we need to think about change in the hospital design, change in the patient flow with open design, movement, touch-free, with more flexible play, with many separate buildings for the hospital, and we need to focus on the natural environment. And thirdly, that is the collaboration and the leadership. I think this is also very important. Should we have the collaboration between the private and the public sector? There should be the equal access to education and skill learning among the private and public sector. And when the pandemic comes, there should be the response, whenever the pandemic response, the private and the public hospital should be considered at the same time. So also the collaboration between the clinical staff and epidemiologists and also is necessary so that the clinical staff can know that the patient safety and clinical outcome and the primary motivator to increase compliance to infection control. And shock up the staff also very important. So we need to maintain the staff capacity during the pandemic. And lastly, the last but not least, the leadership engagement. That is very important factor to ensure the effectiveness of a program to control and prevent the infection. In summary, we need to learn from the COVID-19 and other past crises to create a future-ready solution. Dynamical adjust strategies should be planned beforehand. Prevention and control measures maintained all the time and enforcing right at the beginning of the pandemic. We need to increase the capacity in development, production, cold chain, transportation, and distribution of vaccine. And we need to use risk-based healthcare worker management to maintain the capacity of service. We also need the requirement of innovation on diagnostic treatment and especially the telemedicine, the digitalization. And the requirement of collaboration and leadership is important, and we need to think about the long-term plan and strategy after the pandemic. In Abraham Lincoln, in his statement, he said, the dogma of the quiet past are inadequate to the stormy present. The occasional is high with difficulty, and we must rise with the occasion. So as our case now is new, so we must think anew and act anew. Thank you very much.
Very good morning. I'm Monday Suprani, infectious disease and hospital executive of the Med Park Hospital in Bangkok. As we all know that better at human transmission and immune invasion of the BA.4 and BA.5, the Omicron subvariant, mostly distant phylogenetically from the ancestral Wuhan WA1, has dominated as global pandemic of the COVID within the last few months. Thailand in particular has the first 2 cases of the BA.11529 since 24th of November 2021, 2 days prior to the WHO declaration of the BA.11529 as a VOC. As of the 1st of September, Thailand has 4,652,923 COVID cases and 32,331 of them die. Almost all cases in Thailand now are BA.5/4 at the ratio of around 6:1, with the only 13 cases of BA.2.75, but there is none on BA.4.6. Spanish researcher Elizabeth Diago from IS Global addressed that even prior to COVID-19, the alarm about the lack of the preparedness system for emerging diseases with pandemic potential has been even pre-existed since SARS and MERS epidemic, yet unfixed though. To name a few of lessons learned from the COVID-19 included scientific collaboration and mobilization in vaccine innovation, diagnostic therapies, new surveillance system, especially very interestingly, the surveillance of wastewater, the real-time integrated epidemiological data. Now, the early warning and surveillance system, if existed, would allow us to rapidly contain the viral spreading. This information, contradictory recommendation, has been synergistically led to a decline in public trust and compliance in health authorities, obstacle to governance founded at all levels, which led to an uncoordinated, fragmented response, social inequality, amplified community spread. The author adopted from the European CDC the principle of PRRR, preparedness, response, recovery, and resilience. Several initiatives have been started. On the right side is initiative from WHO. For example, the WHO Hub for Pandemic and epidemic intelligence through better data, better analytics, and better decisions across all aspects of managing public health emergency. European Health Emergency Preparedness and Response Authority for coordinated EU-level action in response for serious cross-border health threat. The WHO Preparedness Framework in cities and urban, focusing on governance, evidence and data, vulnerability groups, high population density and movement, community engagement, health emergency and disaster risk management for resilient cities. Associate Professor Amal Amin, as part of the COVID Action Platform from World Economic Forum, presented top 7 lessons that decision makers need to take on board if we are to survive and thrive in the future crises. First and foremost, the first item, we need more evidence-based decision-making. rather than political best guessing in the absence of facts or even with misinformation. Public and private sectors' involvement in important decisions. Now we need to think about the health and economy as interlinked and repositioning health as an investment rather than a cost. More global cooperation, global health is a shared responsibility. Action or inaction at the local level can certainly affect global health. Hence, global health system standard is urgently needed. Education is the best future investment. Critical thinking is essential in the curriculum. Misinformation, bogus remedies, myths and fake news cost lives. Media, journalists is responsible totally to get the science right. Counter misinformation with science and fact via social media is recommended. Clean environment and climate change has been mentioned. Now, come back to Thailand. As part of the UHPR, or Universal Health Preparedness Response, or Review, 16 WHO delegates on the 21st to 29th of April worked closely with the Thai Ministry of Public Health to share their lesson learned from the COVID-19 pandemic. They captured 3 characters of Thailand response to the pandemic as flexibility, adaptability, pragmatism. The strength of the system included high level of political commitment, established robust health system with a strong universal health coverage, strong community network with more than 1 million village health volunteers, multi-stakeholder COVID response, innovative solution, for example, cardboard beds, bubble and seal strategy, ensuring Thai and migrant workers kept safe and factories still in business. Several issues that could be strengthened included aligning database, barriers in access to healthcare, enhancing universal health coverage, specifically in urban areas, pandemic fatigue and complacency, sustain and share innovations, medical waste management. 2 weeks ago, as a part of the upcoming EPIC meeting, was our EPIC Big Picture Leadership Commitment on the 12th EPIC High-Level Meeting on Health and Economy in Bangkok. They came up with 4 aspects of initiative: health system readiness, universal health coverage as a safety net, importantly, vaccine procurement, sharing, and manufacturing, healthcare workers strengthening, sharing information, and handling with misinformation. This is my personal view of some of the unaddressed issues to share with you. If you look at more or less of the root causes by asking 5 whys, we were not doing very well, honestly, during the surge of Delta, to the level of oversaturated cases in all 50 Bangkok constituency. Proactive measures had been limited. Uncontrolled quarantine measures among illegal migrant workers at the construction campsites had been problematic. These lead to the root causes of how we would be better controlling transborder human trafficking. Never been said, never been addressed, never been fixed, yet a big problem. I know Singapore has been going through these problems before. Successful village health volunteers in controlling Wuhan should have been adopted proactively in cities and urban areas. We move to the people, not the people move to us. Obviously, wild animal industry, the most likely root cause of the original pandemic, never been addressed. The international standard protocol of controlling wild animal business should be well established. Now, safer travel. With new innovation application by all routes, air, sea, and land. For example, portable UVC robotic, self-killing surface material, HEPA-filtered HVAC as a standard feature in vehicles, special quarantine compartment, for example, room, bogie, daughtership, lack of a reliable independent data surveillance system during the pandemic created doubts and trust issues academic institution network would be the appropriate choice. More than 1.5 years, the US CDC has established a national wastewater surveillance system for COVID-19 for more than 1,000 sites around the US, serving as surveillance monitoring for community burden of the COVID-19. Rising of COVID-19 in wastewater prior to rising COVID-19 cases in human and rising COVID-19 hospitalization in population were well demonstrated previously from the Harvard, MIT, and National University of Singapore study, Yale study, the Netherlands study groups during February and March of 2020. Also, Chulalongkorn University group in Bangkok on July of 2020 also demonstrated the same finding. Recently, University of Tartu found various amount of Omicron in wastewater in nearly all area of Estonia. I propose ASEAN should be more vigilant in establishing ASEAN network of wastewater surveillance for COVID-19. This is timeline of Thailand, the green bar, and MedPark Hospital, my hospital, on the purple bar down below. During Wuhan pandemic, started on the 8th of January 2020 until 31st of March 2021, beginning with the first COVID-19 cases outside China. I heard Dr. from Gleneagle, the CEO, you got 25th of January, right? From Singapore, 2 of them. I got one from Wuhan on the 8th of January, the first case in the world outside China. We survive anyway. We start with that lady, and then we move forward with the first cluster at the boxing stadium on 6th of March. And then we got not triple C though, we got CCSA, which means Center for COVID-19 Situation Administration by our Prime Minister, Prayut Chan-o-cha. It's established on 26th of March, 2020. And then we got the first lockdown from the 4th of April, 2020, and being lifted on 20th of July, 2020. And then we moved to Samut Sakhon cluster during 12th December 2020 at Center Shrimp Market. And it spread to hundreds of factories and with migrant workers until 17th of February 2021. Then to several fresh markets around Bangkok suburb during March 2021, all of which involve illegal migrant workers. Disease spread to 27 provinces. MedPark decided to import and acquire a unique yet innovative and more ergonomic PAPR called Clean Space, pulsing on UV light strikes on board, HEPA UVC transporting capsule stretcher, one dedicated external entry negative pressure room at the emergency department, 6 full-feature negative pressure room at the ICU. Now we move to the Alpha pandemic, starting on the 1st of April at Thong Lo, and then Klong Toi cluster right here. But the real game changer started on the 21st of May 2021, when an uncontrolled quarantine of migrant workers with Delta virus, the first in Thailand at Laxi campsite, has led to a complete engulfment of the Bangkok BMA to the level of near-breaking healthcare infrastructure and a nationwide spreading. At MedPark, fully dedicated cohort ward with 45 negative pressure single rooms, fully dedicated cohort ICU with 30 negative pressure rooms, drive-through RT-PCR services, COVID-19 vaccines clinic, and hospital-driven hotel isolation were cumulatively established. We started to do the telemedicine though. We moved to the Omicron BA.1, started on the 24th of November 2021 by 2 Thai women from Nigeria, 2 days prior to the WHO declaring VOC status on BA.11529 and name it Omicron. We have it even before. It engulfed the entire country with the biggest surge ever after untimely travel restriction measure to rapid growing lists of countries with Omicron local transmission, combined with test and go failure to detect Omicron. It was initially portrayed as a mild, non-fatal, desirable pandemic. Pandemic fatigue and complacency has been overwhelmed. Unlimited personal design, the vaccine schedule based on inadequate and balanced information were commonly seen. Then BA2 in May, and now BA4 and 5 in June until August. MedPark provide a dedicated CT scan room with negative pressure at the emergency department, HEPA transport capsule wheelchair, and recently established a one-stop service clinic for symptomatic ARI equipped with negative pressure environment, rapid RT-PCR COVID-19 influenza, doctor visit, prescription, cashier, discharge, and we call it IDARIC, which means Emerging Infectious Disease, Acute Respiratory Infection Clinic. The medical and pediatric clinic with negative pressure exam rooms and sputum collection room have also been recently strengthening features of MedPark. Start with hospital entry triaging via QR code. Only symptomatic ARI with or without fever will be directed to IDARIC clinic. Registration, nasopharyngeal swab, RT-PCR. Only detected patient would obtain history and physical exam by doctor, chest radiography, extra blood work, prescription, cashier discharge with or without follow-up. Admission will be performed by HEPA-filtered wheelchair. What really happened at IDARIC is well demonstrated by a picture on this slide. By far, during 124 days of IDARIC, 3,716 symptomatic cases obtained the services, and 2,747 allow us to do the RT-PCR, 1,748 or 63.63% of which were detected. Since the beginning of the pandemic 2 years ago, the total of 91,446 patients were tested for RT-PCR at MedPark. Around 4.3% were found to be positive before pandemic, Omicron pandemic. Post-Omicron pandemic, as of 5th of September, 37,115 tested, 6,985 of them were detected, which is constituted 18.8% or 4.3-fold increases. From the pandemic until now, we've been admitted the cases into our medical facilities by 3,004 cases to be exact. We delivered 317,084 doses of vaccine for the population. We are fully committed to provide safe and effective, patient-centered, timely, efficient, equitable medical services. But as of COVID-19, it is our obligation to provide the clean indoor air quality and clean high-touch surfaces in the hospital. And thank you for your attention.
So for the Q&A session, I mean, at least for me, thanks so much for the profound presentations from various points, right? There would be so much to discuss. I would want to kick it off first with reminding once again, send your own questions, and there have been a few questions. The first one was about the speaker slides, and there the information is those will be provided if the speakers consent afterwards in the Hublu app. So you will get them for those provided. And then the second question that's here, I wanted to start with as well. In the presentations, it was very clear that processes did change in the operations of hospitals and became more online, telemedicine, home-based medicine, etc. And one of the questions from the audience was, we now already see there is a tendency to go back to face-to-face, and I would want to augment or like include a little bit more to the question, would you be, all of you are inpatient-focused hospitals, so the reimbursement for not providing inpatient care might be not valid for your business models. So the question is, do you see, you as providers, that you would want to go to telemedicine, to more ambulatory, out-of-hospital medicine? Or do you already feel going back to the acute care model is the way you want to go for your own organizations? And Dr. Ramos, potentially you want to start and then we make the turn.
A lot of that is not really dependent on us. It's really patient's decision. And the patients would rather pay for service. In other words, pay from out of pocket rather than going through the queues that would otherwise require government subsidy. No? We have a national health insurance system. We call it the PhilHealth. And it's something that requires a lot of radical changes from within. And we have not been receiving, for instance, we have not been receiving enough of it, no, in terms of the payments. No? So patients, everyone that's universal health care is supposed to be enrolled in it, but the coverage is limited. During the first 3 months of the pandemic, there was a government order that all COVID cases would be reimbursed by the government. And so that's how we got swamped, and that's how we started to triage and collaborate with the government hospitals so that we could also render service to the non-COVIDs. Because remember, during the COVIDs, a lot of the non-COVIDs that are just as serious really refrain from going to the hospital. And being a private hospital, we rely on pay for service. In most instances, only partially covered by PhilHealth. So a patient's decision is a patient's choice, actually. And home care, for instance, at this point, it's really the decision of the patients to stay at home. And we are still working with PhilHealth to have it covered. Eventually, it will be covered because we collaborate with them and we have a way of really finding ways to also lower down the cost, no? Because it's all cost-driven.
Just to play safe, you say patient decisions because the majority of your patients pays out of pocket.
Pays out of pocket, yes, that's right.
Not insurance driven, nor reimbursement driven by government schedules. Thanks very much.
That's correct.
How is your situation?
I will take. Thanks. I will take a different approach, actually. I think the pandemic has accelerated what we wanted to do in Malaysia. And we are moving into a home-based care. And in fact, we are trying to discourage patients from coming to the hospital. In Malaysia, outpatients are out of pocket. So whether they come to the hospital, whether they do it online, it doesn't really matter, right? And in fact, if you do it online, the cost is actually cheaper. And in Malaysia, we are looking at medical inflation as an issue. And whatever we can to bring down cost of treatment and delivering care, we will do it. To be frank with you, it is actually cheaper to do it online than in clinic, right? And that is the model we're looking forward, at least for IHH and Gleneagles. From a patient perspective, though, if I'm a patient, I would like to see the doctor personally. If money is not an issue, I'd like the doctor to take my pulse, palpate me. I'd like the handshake. To me, touch is important. But that is just preference. But from a cost perspective, it makes a lot of sense to keep the patient away from the hospital.
And do you have insights on the patient's perspective? You now said the preference might be to be in person because they want to have the touch. But from an outcome perspective, would you say they see the same outcomes? So assurance, guidance on the regimen that you have, etc.?
The take-up is more on follow-ups. For new patients, they would come to the hospital because you need to palpate the abdomen to look at the lump, the size, the shape, the color, and all that, right? That cannot be seen properly over a video, depending on the quality and the resolution also. But for follow-ups, the uptake is pretty good.
That's correct. It's a hybrid, actually. It's becoming a hybrid now. And so the first visit would require a face-to-face, and then subsequent follow-ups would actually be more convenient if you go online.
Thank you. Let's just close the loop. Dr. Mondej, what is your situation here in Thailand?
Hello. Yeah, it works. At MedPark, we got a self-pay as the main patients, and we have a government-sponsored pay to receive another hospital service at our hospital network. We have another 8 hospitals in our same network. So the government-sponsored patients would be transferred to another 8 hospitals. And we try to establish a dual system in MedPart just to make sure that we could be able to maintain COVID and non-COVID in the same hospital, but with a separated environment so that they could be able to be more comfortable to come over to the hospital and got a touch, got a face-to-face with the doctors. We are not really, getting used to, the remotes and distant treatment without touch or without talking. So we try to reestablish a dual system in our own hospital.
Thank you. And Professor, finally, Vietnam?
Yeah, in Vietnam, so every COVID patient is free of charge for even you go to the public hospital or private hospital. So that is the law from Vietnam because any pandemic comes, so the people do need to pay for the hospitalization, even they go to the private hospital. And but as I said in my presentation now, during the COVID-19, we need to shift from the acute care to the home care. And we found that like myself, when I do in the home care for the patient, I found it's a very interesting thing that we do with something it never we done before. So everything is home care. So, but the problem is now the assurance still do not cover for the home care yet. So, but when I look at in the USA and in the European country, I found that they already the assurance already cover for the home care, for the telemedicine. So I think this is a very good thing. So they also expect that until 2025, about 25% of budget for the assurance can be transferred to the home care for the digital telemedicine and with the digitalization. So I think maybe in Asia, I asked around, but nobody, the assurance still no cover yet. So I think it is better that we need to, the assurance should be covered, the national assurance should be covered for the home care as well, for the telemedicine as well, so that we can, many patients can access the home care. Yeah. I think it's very important for the next, to prepare for the next pandemic because it will improve the patient do not need to come to the hospital very frequently, and it will take the time, it's safer, more safe for the patient with more effectively, with less the cost.
Exactly. So to sum it up, you would be prepared to cater for it if the incentives are right,
Yeah.
right? Quite obvious.
Yeah, just important, Herbert, that more and more of the non-COVID, the chronic cases, are the ones that are actually availing of the telemedicine because it's a chronic case and they establish relationship with their doctors. Occasionally they visit for a face-to-face, then it becomes a follow-up. So it's the non-COVID that eventually will actually become the main thing.
When we talk about with the digitalization for the COVID, even with the chronic patient, or even with the acute care patient, we still can follow up at home using the digital technology.
I'd like to pick up another question here from our audience, and it most likely goes a little bit to either Dr. Mondage or Professor Thu, because the question is, we talked about fatigue about the pandemic, and the question is very obvious, when is it over?
What do you think?
And I mean, you just shared the variants, right? Very profound. And so
when the disease is over or when we is over?
Hopefully not us. No, hopefully not us. But I interpret the question from the audience. I'm not a medic. And I love learning about PA1, 2, 3, 4, 5, and potentially it goes up to 20. But when can we focus on different things again?
So remember that in 2009, we had the H1N1 pandemic. And actually in 1918, we already had the H1N1 pandemic. And then 2009, we had H1N1 pandemic. And after that, we never say that pandemic, we never say that it's stopped. And H1N1
endemic.
And H1N1 become endemic. So I I want the coronavirus, SARS-CoV-2 now will be the same. Maybe it will be reduced gradually, and then it's become endemic, and we can like the seasonal coronavirus something, and we need to vaccination every year, something like that.
Herbert, you may probably want to know from a non-infectious disease. I'm a cardiologist, and I see a lot of heart failure cases and chronic cases. But I think the answer is really, there was a time as a CEO of the hospital that I was focused on our flagship programs of neurosciences and cardiovascular and cancer and wellness. But I realized that infectious disease is going to stay, and we need to invest on infectious disease because of the climate change. Climate change has an impact on migration of animals and the way people live. The climate change will have impact on the monsoon and the drought and the flooding here and the drought elsewhere, which actually promote malnutrition, which actually diminish the immune system of the individuals, which will lead to a lot of viruses, I think, and a lot of infections. So that's precisely why I think me as the CEO, we really need to invest on infectious disease and really having the mindset that a lot of these things can happen again.
Getting back to the question about when it would be disappearing, or
Not disappearing, I think. The
yes,
pandemic thing
not
was
us.
implied, but
Well,
when
well,
will
that-
it not be the focus so much anymore?
Well, the personal observation has been that it's a cyclical. The disease came around 3 months' time and then disappear or get lower down by 3 weeks or to 4 weeks' time. It's like a cycle. And the last cycle has been from May until July, and August was a kind of off cycle here in Thailand. In September, this month, it's going to be the month that would be proven which way they are going. If they are going to repeat itself again, but as of now, the information that we got seems like it's embedded. It's embedded in the society. It's embedded as an endemic illnesses. The level of endemicity depends on the population behavior. If your population behave different ways, we would got a different level of endemicity of COVID. I'm not sure whether you agree, but that would be a real world. And we need to deal with this. COVID is going to be endemic at different levels, at the different localities. As a hospital, we need to make sure that we could be able to take care of the patient, both COVID and non-COVID, as a dual system in our hospital or even telemedicine or whatever. It's going to be a dual system from now on. We need to manage on both systems. That's what is going to happen. When it's going to be totally disappearing, I'm not sure whether I could answer that question.
Well, I'd like to insert on myself. I landed yesterday, and I was just totally impressed with the size of your international airport.
Oh.
And apparently it's a hub where within Europe and everyone. And I guess the bigger the international airport of the country, the less likely that COVID is going to disappear.
Yeah, and I guess we are aligned that it will not disappear, but the question is the endemic. And just as a fun note, I understand how we behave might lead to, from the pandemic, make it endemic. I'm from Germany, and the biggest festivity, the Oktoberfest, is going to start soon, and there will not be any measures at all. There will not be any measures, I repeat. So rest assured, there will be a big push to making it quickly an endemic and not a pandemic anymore. So sorry for that. One final question, which goes into the direction of, there was a lot of learning and there was a lot of what you said, many of you shared, right? For example, the thing, let's do evidence-based decision-making. At the same time, politicians or those who take decisions are not always evidence-based. They might need to look into other issues, and there's loads of issues in the world currently. It's inflation, it's the foreign exchange rates, it's climate change, it's food shortages, it's other crises that likely could grab away the attention that for the last 2-3 years now was on the pandemic or healthcare. Would you feel, or are you confident that in your system, in your country, in the world, the needed level of attention will be there and that we will be prepared better? Because Professor, what you shared so nicely with the flu around 1900, right? Same thing. And I naively would have said, quickest time to developing a potent vaccine. We had the tools, we had the knowledge is shared quicker than ever before. Everyone at the same time had the knowledge about what's happened. Did we get out of it so much better? Potentially, but still the misinformation, etc., it could have done even better. So question, will the focus remain and will we really be better prepared? Or will we, as your Lincoln quote, will we need to, with the next crisis, adapt quickly to the crisis again? And here, not sure who wants to go first. Any volunteer?
Okay. You know, the pandemic is going to happen again. Sometimes it might not be 100 years. It might be shorter because of the travel, because of the climate change, because of so many things. And I think this trauma, we were traumatized by COVID and we have learned a lot. And we have, the difference is that now we have technology and we have the media where we share data and we have access to evidence-based data. So I think we're much better. The challenge is really not learning, but the challenge is remembering. People usually forget and get distracted over time, and then we go again. And I think what we should really establish is that certain things that we have learned and certain things that we know are no longer necessary or no longer of value should actually be removed. And this is where the governance part comes in.
Eugene, I think he's absolutely right. We forget very easily. We forget very easily from one crisis to the other. And I think it's just a matter of time before another crisis comes and we forget about COVID-19. Malaysia is pretty blessed. We don't have some of the problems we see across the world. For instance, in Ukraine, for instance, in Sri Lanka. And I think it's about priorities, right? So each country will have a set of challenge that they will have to prioritize. And I don't think there's one rule that fits all. We don't have issues with unemployment. We don't have issues with hunger that much. Right, so yes, in Malaysia, for instance, COVID-19 is still very fresh in our hearts. And we are taking concrete steps, very concrete steps to make sure that the future pandemics that come our way will be able to manage it better, private and public. And one of them is the synergy between government and private hospitals. So previously, private hospitals and government hospitals, we were in silos. Government hospitals, private hospitals. But the pandemic has accelerated the synergy, the communication, the coordination between these two sectors in terms of resource sharing, in terms of information sharing, in terms of knowledge sharing. So this is one of the take-backs that we have learned from COVID-19. And I think COVID-22, COVID-23, or whatever may come, will be better off.
Yeah, I agree with all of you. I think that it's very important that we need to remember what happened. I think that you all agree that the crisis will be occur in the next future. We don't know. Even now, we don't know when is the next wave of the COVID-19 come or it will stop. So if the COVID-19 stop, is there any another crisis and the pandemic will come? So we don't know. So very important that we need to remember what already occurred and we need to prepare for that. We need to prepare for, so everybody need, not only in the hospital, I think it's also in community. We need to explain for every people to prepare that the crisis will come and at least the infection control measures we should respect. For example, after the COVID-19, we remember to hand hygiene or wear mask or something. But after when it's a little reduced, so the people like to neglect to wash hand or or something, or doing something like plan for the new. So in the hospital or in the community, in government, we need to have the plan for the crisis if it comes, so that we can right at the beginning when the crisis is and pandemic it begins. So we need to we had to prepare enough to control it easily. Yeah.
Excellent, thank you. And with this, unfortunately, we are on top of the hour already. I know there's a few more questions from the audience. Please, I just want to ask you afterwards, approach your panelists directly and ask them. And to sum it up, I think what we've done today was, at least for me, one of the conclusions to overcoming COVID-19 jointly. It's not the tendencies of nationalistic trying to solve it individually, but sharing as a global community, evidence, fact-based, countering misinformation, and standing together. And I'm personally still impressed by what has been accomplished and how it has been overcome. I shared beforehand, I was a CEO in a German hospital, and when I heard what the guys there in the hospital did do on the front lines day in, day out, in situations of dire demand or unknown what the virus can do, it's inspiring, and many people now understood the value of healthcare, and let's make sure it's not forgotten too quickly. Thanks very much for today. Thanks for your attention, and enjoy the rest of HMA.